Hello, I am Charles Kanan, Senior Provider Education Consultant at Palmetto GBA. As a Medicare contractor for CMS, Palmetto GBA is tasked with preventing claims payment errors. Our Provider Outreach and Education Department helps providers like you understand the fundamentals, significant changes, and new initiatives of the Medicare program. This includes national and local policies, procedures, and issues identified through data analysis. Our goal is to create a strong health information supply chain. This helps reduce incorrect billing and payments, and at the same time, ensures that your patients are receiving the correct level of care that they need. Today, I want to talk to you about Hospice General Inpatient Care, or GIP. When it comes to length of stay, Medicare policy does not specify the number of days GIP is allowed, although it is intended to be short-term. A national study of nearly 3,000 GIP providers indicated that 1/3 of all GIP stays lasted longer than 5 days. More than 11% of all GIP stays were 10 days or more, and 2% lasted longer than 3 weeks. Our breakdown of stays by facility type showed that inpatient hospice had an average length of stay of 15.2 days. Inpatient hospital stays lasted an average of 9.7 days, and stays in skilled nursing facilities averaged 23.2 days. To try to determine potential causes for extended lengths of stay, Palmetto GBA compiled comparative billing reports based on providers billing for the GIP level of care and sent a letter to all providers at the 80th percentile. We then conducted group and individual teleconferences and identified 3 primary areas for you to focus on to help avoid long lengths of stay. These areas are evaluation, discharge planning, and documentation. First, you need to thoroughly evaluate the need for the GIP level of care. Remember, GIP is for pain control or symptom management which cannot be delivered in other settings, such as the patient's home. Upon transfer to the GIP level of care, be sure that the medical record includes the precipitating event, such as the onset of uncontrollable symptoms or pain. Your documentation should also include any in-home interventions that were unsuccessful at controlling your patient's symptoms or pain. Once you determine GIP level of care is required, you need to address discharge planning. Remember that discharge planning begins on admission and continues throughout the GIP stay. We all understand GIP is not intended to be custodial or residential, and that once the patient's symptoms are stabilized or pain is managed, he or she must return to a routine level of care. The patient may remain in a facility, but Medicare will not pay for GIP if the medical records do not indicate a clear need for GIP level of care. These first 2 steps identify the need for proper and complete documentation, which is a third area of focus. Here are 5 recommendations to help ensure that your documentation supports the GIP level of care. Number 1, describe the services provided. Number 2, document care that the patient's caregivers cannot manage at home. Some examples are frequent changes in the dose or schedule of medications or the need for IV medications. Number 3, identify the precipitating event that led to GIP status. Number 4, describe failed attempts to control symptoms that occurred prior to admission. And number 5, identify specific symptoms that are actively being addressed. We believe that if you implement these recommendations into your internal processes, you will create and maintain a strong health information supply chain. This will enable you to deliver the best care possible and avoid costly errors which could result in the loss of Medicare coverage and payment. I'm Charles Kanan with Palmetto GBA. Thanks for watching.